Hello everyone, this is Dr. Meenakshi Gupta. Today I am going to take another topic of pharmacology, that is anti-anginal drug. So what all anti-anginal drug we have? We have nitrates, beta blocker, calcium channel blocker, potassium channel opener and other or miscellaneous anti-anginal drug. So this nitrate, beta blocker, calcium channel blocker, already I have covered, will be giving link in the description box. Then in today's video I will be discussing mainly the potassium channel opener and other or miscellaneous anti-anginal drug. Now coming to the potassium channel opener, now how many types of the potassium channel they are there? So we have voltage gated just like other sodium and calcium channel. Here also we have a voltage gated potassium channel which are going to open whenever the cell is depolarized. Okay, so this channel it open and it is going to bring back it to the repolarized state. It is mainly present in the vascular smooth muscle plus other smooth muscles, and it is going to cause repolarization. Then number 2, calcium activated potassium channel. This is opened when there is a increased intracellular calcium ion that is there within the cell. So with the increased intracellular calcium ion, that is going to cause the opening of the potassium ion, and potassium they will come out from the cell. Suppose this is the cell, the calcium will move inside and this is going to cause the opening of this channel and potassium will move out, and this also helps in the repolarization. Then number 3 is ATP sensitive potassium channel. We have sodium activated potassium channel, they are also there. Receptor operated potassium channel, they are also there. So ATP sensitive potassium channel. So their opening and closing, they are mainly dependent on level of ATP. Okay, so if this level, if it is increases, then the channel it closes, and if it decreases then there is a opening of the channel. So this group of drug Nicorandil, it mainly acts by acting on this channel. Okay. Remember one basic thing, in any cell usually the cell it is negative inside and positive outside. You know, it is because of the increased concentration of the sodium outside and potassium inside of the cell. So this is, we say, polarized cell. So we can draw it like this. Then what happens if there is a activation, there is an influx of the sodium ion. Now this leads to what? So usually the potential it is negative, voltage is negative. Now with the influx of the sodium ion, what happens? It is going to become less negative, and ultimately what will be there? It is going to, suppose here it is comes 0, it will move towards the positive, and this we will say now the cell is depolarized, right? Now again there is a efflux of the potassium that leads to the repolarization. So this is a repolarization of the cell. Now if it moves further to more negative, this is called hyperpolarization. So polarization means it is now more away from this depolarization, or depolarization, it is going to take more effort. So hyperpolarization, it is going to cause relaxation. Okay, and with the relaxation, what will happen? There will be the smooth muscle relaxation is there, vasodilatation will be there, there will be fall in blood pressure. Now coming back to the drug Nicorandil. So how the Nicorandil they are going to act? They are going to bind with the ATP sensitive potassium channel, and they are going to antagonize its action. Okay, they are going to antagonize its action, and with this what will happen? They are going to open this potassium channel. So once this potassium channel it is opening, always remember the ion they move from higher concentration gradient towards the lower. Now potassium, it is inside, it is more. So once there is a opening of the channel, what will happen? This potassium it will move outside. So there is a efflux of the potassium, and with the efflux of the potassium, what will happen? It is going to cause the hyperpolarization of the cell and causes the relaxation. What are all the drugs which are going to close this channel? It is sulfonylurea group of drug. This is important anti-diabetic drug, glibenclamide, glimepiride, all they act by blocking this ATP sensitive potassium channel. Then what will happen? They are going to cause, by the closure of that, it is going to cause depolarization. There it is going to cause the sulfonylurea group of drug. They act by closing the ATP sensitive potassium channel, and they are going to cause the depolarization. So with the depolarization, what will happen? There is an influx of the small amount of the calcium ion, and then what will happen? The insulin containing granules, they will come and bind with the membrane, and what will happen? There is a efflux of the insulin. So it is like, suppose this is a pancreatic beta cell. Here the insulin, it is stored. What will happen? This membrane, it get fused with this. Then there is a efflux of the insulin. This is a pancreatic beta cells. So sulfonylurea group of drug, what they do? They block this ATP sensitive potassium channel. By blocking this, what they are going to, cell will depolarize. So with the depolarization of the cell, what will happen here? A small amount of the calcium will enter, which is going to cause a fusion of this membrane with this, and there is a release of the insulin. So Nicorandil, they are going to cause the opening and causes the hyperpolarization, and there is a relaxation of the smooth muscle. So it is, you can see here, this is one mechanism. Other one is like a nitrate, they are also NO releasing from the vascular endothelium by increasing the level of the cyclic GMP. So by this, they are going to cause the vasodilatation of both arteries and by this veins. So they are both arteriolar dilator and venodilator. So artery की भी dilatation होती है and venous की भी dilatation. So this is going to decrease both afterload as well as preload. So by decreasing the preload, we can use it for the stable angina. So it is useful in both stable angina and for the variant or vasospastic angina. So this is how this Nicorandil, it is going to act. So what are the other potassium channel opener apart from the Nicorandil? We have few other drugs which are potassium channel opener. Closer I have told, sulfonylurea opener, they are digoxide, Then we have a minoxidil, pinacidil, chromocalin, and this Nicorandil. Okay, so earlier we were using this one because they also cause a vasodilatation, so we're using for as an antihypertensive. Here important is this minoxidil. It causes hypertrichosis, so that's why it is used for the male type of baldness, male pattern baldness. Topical, it's topical preparation, male pattern. So this is important MCQ. So otherwise as an anti-anginal we are using the Nicorandil. So what are the other important property? The pharmacokinetic, we can give it by oral route, metabolized in the liver, excreted in the urine, and its metabolism, its elimination, especially it is a biphasic. So initial, that is a rapid phase with a half-life of 1 hour, and a slow phase with a half-life of 12 hour. And because it is going to cause a vasodilatation, so side effect will be related with that. So there will be flushing, palpitation, weakness, headache, dizziness, nausea and vomiting. And apart from that, there is a large aphthous ulcer in the mouth which are reversible, so they heal on when we stop the drug. So just like the nitrate they also act by releasing NO, and there we see the nitrate tolerance, so that is not seen with Nicorandil. So where we can use, this is the second line anti-anginal drug, so we can use this one in resistant angina along with the other drug. Okay, so this is a second line anti-anginal drug. And in MI before angioplasty also, they say it is going to improve the outcome. So this is about the Nicorandil. Now coming to the newer drug, so we have the three drug here, one more, that is it, already I have discussed that one. Dipyridamole. So we have Trimetazidine, Ranolazine and Ivabradine and dipyridamole. Coming to the Trimetazidine. So how this drug it acts, what is its mechanism of action? So this group of drug, especially these two, they are not going to decrease the heart rate. Okay? They do not act by decreasing the heart rate or any effect on the blood pressure. Now how they are going to act? Coming to the first one, Trimetazidine. So remember one thing, the myocardium, it uses as a fuel the fatty acid, 60 to 70%, this one for the its ATP, and 10 to 30% the substrate uses. It can use the glucose, lactate, pyruvate, all that. Right? Now what happened in ischemic myocardium? Now there is a, during the ischemia, use a different color, when there is decreased coronary flow, decreased oxygen. Now what happens? The glycolysis will happen and there is a increased production of the lactate. Despite this thing, the paradoxically, in spite of using this, the ischemic myocardium, they are going to use fatty acid as its substrate. Okay. Now what happens if it is using fatty acid as its substrate? Because of this fatty acid metabolism, fatty acid oxidation, it is going to inhibit the pyruvate oxidation. Because here, because of this increased lactate, there is decrease in pH and cell function that is impaired. This is already going on. Okay. Now in the ischemic myocardium, because of the decreased coronary flow, decreased oxygen, what will happen? The glycolysis will happen. There will be lactate production will be there, which is going to decrease the pH, and that is going to impair the cellular function of the myocardium. Despite all this, the myocardium, they are going to use fatty acid as its substrate. And you know, for the metabolism of the fatty acid, we need more amount of the oxygen. This is one thing. So already there is a compromised oxygen is there. Then second one is, once this fatty acid, this metabolism, they are going to inhibit this pyruvate oxidation. If this does not happen, then what will happen? Lactate accumulation will be there. This gets accumulated, then again the same thing, ye wali sari cheez, this, all these will happen with this also. So cell function that is impaired. Now trimetazidine, what it does, it is going to inhibit the main enzyme which causes the metabolism of this. And what is that? That is a mitochondrial long chain 3 ketoacyl coenzyme thiolase. It is going to inhibit this enzyme. Once this enzyme it is inhibited, then what will happen? The fatty acid metabolism will not happen, and all these things, they are inhibited. So how it is going to give a, it is improving the cellular tolerance of the myocardium by shifting its metabolism from fat to glucose. Now it is going to use a substrate, kaun sa use hoga? Now the glucose will be utilized, and for the utilization of the glucose, the oxygen requirement for the generation of same amount of the ATP, that is less. For the oxidation of the fat, we need more amount of the oxygen to generate ATP, and for the glucose, less amount of the oxygen is required to generate the same amount of the ATP. Okay? This is how this drug, it is going to help in the angina. So we give it by the oral route and metabolize same, it is going to metabolize in the liver, and half-life it is a 6 hour with this. And side effects, they are minimal, headache, flushing, all that will be there. And reversible Parkinsonism, that is seen with this drug. And this drug, it is also used as an add-on drug. ठीक है, इसको बाकियों के साथ add करते. This is not the primary drug. So this is about the trimetazidine. Now coming to the second drug, that is a Ranolazine. They are going to inhibit the late sodium channel. So by inhibiting this, what they are going to do, they are going to inhibit the sodium calcium exchanger. Okay, इसको inhibit. So what will happen now? Because of this, there will be decreased calcium load in the myocardium, and this is going to decrease the myocardial contractility, and by decreasing the myocardial contractility it is going to decrease the oxygen demand. So this drug, it also decreases the it does not have any effect on the heart rate, okay, but definitely it is going to improve the exercise tolerance, whereas trimetazidine, they have no effect on the exercise tolerance. So this is a one mechanism of ranolazine, the main mechanism. So another one is just like trimetazidine, they are also going to inhibit the same enzyme, mitochondrial long chain 3 ketoacyl coenzyme thiolase, okay. So this is one number one mechanism, and this is a number two, but this is the main mechanism, and this is the additional mechanism of, and this also we give it by oral route, and it is metabolized by the enzyme. We give it a oral route with a good bioavailability. Half-life is 7 hours, and it is mainly metabolized by cytochrome 3A4. So we can see the interaction with this group of drug. So this is about the ranolazine. This is also used as an add-on drug. Now coming to the number 3 newer drug, that is Ivabradine. Ivabradine. Now they act by blocking funny current. Now what is this funny current? Okay, so there is a pacemaker potential, funny channel we say. Funny channel sodium current. Now to make you understand this, you must know about the pacemaker potential. So what is the cardiac pacemaker potential? Now which cell act as a pacemaker? It is a SA node. So SA node, how the SA node, their potential is there. So this is a resting membrane potential 60 millivolt. This is I am drawing the potential of SA node, and this is a another threshold voltage, that is 40 millivolt. Now the resting membrane potential of SA node So I'll just explain it. Okay. So it is not fixed. So this is a resting membrane, just like if you see the working atrial or ventricular myocytes, their resting membrane potential, it is like this. We draw it like this. So this is fixed. Here there is a continuous change is there. This is phase 4, 0, 3 and 4. And this is very important to make it a pacemaker. Pacemaker means it has got a property to generate its own impulse. So it has got the property of rhythmicity, automaticity. So automaticity is cell is going to generate its own impulse, and it is present in SA node, AV node, Purkinje fiber, but maximum it is at a SA node. Now how this SA node, they have this property, why they have this property? So This already I have told, this is a depolarization. If you remember the previous one, while telling you the Nicorandil, this is a depolarization. See here it is a plus 0 and plus. So this is a repolarization. So depolarization happens because of the inward movement of the positive ions. Repolarization, it happens when the positivity, because here you can see what is it's happening, it is going towards the positive, and repolarization is again it is coming back to its polarized state, right, till here. But once it comes to near -50, then what will happen? And this repolarization, because it is going moves towards the minus, then what will happen? The cell, they are going to lose the positive ion. Here what it is losing? It is losing the potassium ion. So there is a potassium efflux in this one. And for the depolarization at SA node, there is an influx of the calcium ion. Now what happens here? Once the potential it reaches to this point, ठीक है, एक बार यहाँ पे अगर आ जाता -50, then what will happen? This potassium efflux, there will be a decay, थोड़ा थोड़ा कम होना शुरू हो जाता है. Then what will happen? It will move toward like this, ठीक है. It is, that's why it is moving like this. Instead of moving this way, hyperpolarization, instead of going this, it is moving this way, ठीक है. So what will happen here? This is because of the decay in the potassium efflux. There is a decay in the potassium efflux. So now this cell, it is here, we'll say it is a under the hyperpolarization. It is going towards the hyperpolarization. So once it is going towards the hyperpolarization, then what will happen? The sodium channel, they get open here at this phase. Then there is an influx of the sodium ion that leads to the potential of this cell till here. Okay? They are going to cause the influx of the sodium ion. This is, we say, diastolic depolarization. This phase is called slow diastolic, this whole thing, depolarization or pacemaker potential. Okay, this is a pacemaker potential. Here this is a pre-potential, you can say, before the potential. यहाँ इससे यहाँ wave आने से पहले, this is a slow diastolic depolarization. Now initial is, this is part is because of the decay in the potassium efflux. Then what will happen? So instead of going this, once there is a decay, then what will happen? There is a opening of the sodium ion and sodium influx will be there. Then it is moving towards less negative. Then here there is opening of the transient calcium channel, sorry. So there are three type of the calcium channel. One is a L type, T type and N type. So T type, that is transient. It is not long lasting. For a very short period of time they are going to open and there is influx of the calcium ion. And for this pacemaker potential, now you know the three type of ions they are involved. One is there is a decay in the potassium efflux, then there is an influx of the sodium, influx of the calcium. Now this Ivabradine, what they are going to, and why it is called funny, usually what happens, this sodium channel, it opens in depolarization. Okay, when the cell it achieve a certain threshold voltage, okay, then this channel they open. Here what is happening? This sodium channel, they are opening in hyperpolarization. So that is something they say, even both the positive channel, the sodium and the calcium, they are opening when during the hyperpolarization. This is, they find it something funny. So that's why it is a funny sodium channel. So this Ivabradine, what they do, they act by blocking this. यहाँ पे करती Ivabradine, it is going to act over here. And this funny channel, they are present at two sides. One is here at the pacemaker SA node, and second one is it is present in the retina. So at these two sites where this channel they are there. So Ivabradine, they are going to inhibit this. Then what will happen? They are going to decrease the SA node. क्या करता है SA node? They are going to increase the heart rate, the heart automaticity that is maintained with the SA node. So any drug which is going to inhibit this, that means it is going to decrease the heart rate. So by blocking this funny current, I stands for current. Okay. So what they are going to do, they are going to decrease the heart rate. That's why it is called a bradycardic agent. So this is a novel drug which has got only this action. They are going to decrease the heart rate. So like if I compare this one with the beta blocker, so beta blocker, they do all the negative inotropic, chronotropic and dromotropic. So they are going to decrease heart rate, contractility and conductivity. Whereas this drug, it is only going to decrease the heart rate. No effect on the force of contraction, no effect on the conduction. So this is the difference between this and beta blocker. So this is a purely a bradycardic agent. This also we use it for the treatment of angina. By decreasing the heart rate, it is going to decrease the cardiac work and oxygen demand will be less. So this property, it will be going to help for the anginal patient. So this drug also we give it by oral route and it get metabolized in the liver. So again the interaction with the 3A4 that is seen. So here the important adverse effect is because this funny current, they are also present in the retina. So vision, it has got the nocturnal vision that is impaired. So there is a visual impairment that is seen with this drug. Now where we are going to use this drug, this is used for the chronic stable angina. This is one use. Another one is it is also used in grade 2 to 4 congestive heart failure. So these are two uses of Ivabradine. Now coming to the third, and this one, dipyridamole. Next. Now how this drug, it is going to help. This drug, it is going to increase the level of adenosine, local level, okay, by inhibiting its uptake and blocking its degradation. So it is going to increase this adenosine and it is going to cause the take care of local ischemia. So vasodilator action that is seen with this drug. Now it is going to act on what? It is going to act mainly on the resistant arteries or resistant arterioles. So by that, there is one very important phenomenon, coronary steal phenomenon that is seen with this drug. This already I have explained. I'll show you this diagram here. So coronary steal phenomenon, what is this? So this is again all the epicardium, myocardium and endocardium. Okay? So this is the main conducting artery and here adenoma is there. Then what will happen? This part, it is a maximum ischemia that is there, whereas the which is away from this, you can see here because of the ischemia, the dilatation of the resistance vessel that will be there, whereas this side the maintain their resistance vessel, they are going to maintain the tone. If you are going to give the nitrate, they are going to cause what? They are going to cause the vasodilatation of this main artery without affecting this one. This is not affected. Whereas dipyridamole, what they are going to do? They are going to cause a dilatation of this. So this is already dilated. So they are going to cause a dilatation of the artery in the non-ischemic zone. Then what will happen? There will be diversion of the blood from here to here. This is called coronary steal phenomenon. So what are the other that's why this one is not used, mainly used as an anti-anginal. So it also inhibit the platelet aggregation. So we can use it as a anti-platelet drug. So this is all about the anti-anginal drug. So what I have covered in today's video, all of them, they are usually asked as a short note, like Nicorandil, that is important short note. Then Ranolazine, that is important short note. Dipyridamole, this coronary steal phenomenon, this is important short note. Then funny current, what is that? Ivabradine, that can also be asked as a short note. So if you like my video, please like it and share it and subscribe my channel.